So Dr. O'Malley says, I'm going to use PARP inhibition in platinum-sensitive relapse if she doesn't have a biomarker, because I can give Bev later. Do you use that same justification if she's BRCA? Because if she's BRCA mutated, then you can say, I always use BRCA later. So now I can give her Bev. In other words, in the germline BRCA patient in the platinum-sensitive relapse, do you use more PARP or less? Because I actually use less in the platinum-sensitive relapse because we agree.
Because you don't want to help her more.
No, because I can give it later. Again, the sequencing, when I look at a patient, I want to maximize her success. I want her to get all of my agents, and I do not want her to have suffer chronic toxicities. And long-term bevacizumab, I'm not sure what you mean by the long-term toxicities of bevacizumab. Bevacizumab is tolerated very well as long as you keep the blood pressure under.
Yeah. Cumulative toxicities, I said. Cumulative toxicities or prolonged use. It's clearly you see increase in renal. Yeah, there's multiple reports.
Proteinuria.
Yeah, correct. And then which leads to then renal dysfunction.
So do you use more PARP in sensitive relapse with BRCA or less?
I use more.
What was the question again?
In the platinum-sensitive relapse setting, do you use more PARP or less?
With
so
G-BRCA, right? With
G-BRCA,
the G-BRCA
yeah.
patient.
Or
So,
somatic.
well, I think, again, that's another discussion with the patient who's got a germline BRCA mutation. She's going to have a terrific response to platinum taxane. And again, it is a discussion. If she's rendered symptom-free with a platinum doublet, I know that the PARP inhibitor is going to work. I know it's going to work then. And we're going to be following her, exactly, it may be a little, and she may say, look, I don't really want the toxicities, or yes, I want to do it because I've read about all the trials. More or
less in the BRCA patient, more.
Precision medicine.
So I do think that gives you the option of watchful waiting,
Yeah.
following our serologic marker and symptoms, and utilizing then the PARP once you see the disease becoming active again, because you have that ability to treat with that PARP before they become symptomatic. So I think that's an option also.
Yeah, and my point that I was going to make, and I sort of forgot it, but it was that you really get a sense of that clinical progression of the patient. I mean, if that BRCA carrier is, maybe she normalizes her 25 down to 40 or something, then I would certainly consider using a PARP inhibitor as maintenance. Absolutely.